Thanks, Rick. We were commenting that we could have doubled the time for the panel here if we just cut everybody's bios, about 3/4. I want to try to take you back up to a little higher level now. It's very possible to think that the world is about to end in healthcare. And I agree with Hugh that it's not. We've been through many trials and tribulations, and we will figure this out. And there are some very amazing things that are starting to happen. And I want to focus on a couple: quality, integration, transparency, and some of the very new treatments that are going to deal with the cost issues that we've got. You've heard about all the issues around the challenging environment, but I want to talk about two of them in particular. This whole issue of uneven quality across the country and very fragmented care. Those are major causes in our increasing healthcare spending, and there's something that we can do something about. We can't change much what's happening to the aging population, or many of the others that are on that list, but we can deal with those too. So let me spend a few minutes talking about them. First, the uneven quality. This map shows the rate of death per 100,000 people in various states. The dark blue, that rate is about 63 to 70 per 100,000. In the red, it's 100 to 150. It's twice what the dark blue is. Now, it's not related to race. You can see the one for whites only next to it. It's almost the same. You can cut it by socioeconomic group or any other race or any way you want to do it. It's about the same. We've got a twofold difference in death rates that could be solved by medical care across the country. Now, this one also shows, I noticed, that if you want to have eternal life, you probably ought to move to Minnesota or Wisconsin because they're white. But that's a twofold difference. Look at what Medicare spends across this country per Medicare beneficiary. In Miami, it's $17,000 a year per Medicare beneficiary. In La Crosse, Wisconsin, it's $6,000. Does anybody think that the care in Miami is 3 times better than what it is in La Crosse? It's not. The interesting thing is you can pull up a whole bunch of maps like this. I was looking at one yesterday that showed the rate of prescriptions, the number of prescriptions per Medicare beneficiary in various parts of the country. The low end, shockingly, was 50 per year. The high end was 120. Now, what are these disparities? What are we going to do? I think the answer is that we are eventually going to get to competing on value. We've been talking about competing on value for years, and all of us stand up here and say our place is the best value, and nobody's ever had a way to show that. Ever had a way. Until now, I think we're getting closer. We're doing one experiment. We're experimenting on things with a number of different insurance companies, but we've got one thing going with United Healthcare. United has health costs on about 120 million people, health costs over time. We have health outcomes at Mayo Clinic on about 5 million people. And we're trying to bring in a number of other healthcare organizations, large healthcare organizations, that also have the outcome data on a large number of patients. And we can put that together with the long-term cost and say, what does it cost to take care of a breast cancer patient over 10 years or 20 years? And what are the outcomes? And what is the cost of taking care of a patient with a hip fracture over 10 years or 20 years? For the first time, I think we're probably going to get that information. What have we got here? We're probably going to get that information, and I think we're going to start seeing it in the next year and a half. So for the first time, we will really be able to compete on value. From my shoes, it's going to be very interesting because I think we're going to find some places where Mayo is clearly a great value, and I'm also sure we're going to find some places where we're not. So we're going to have to get to work and figure out what the best practice is in various places. And this is going to allow us to start doing that. The other big issue out here is fragmentation. the whole issue of you go one place for a lab, you go another for x-rays, you go for one doctor at one place, another doctor at another. We have wonderful electronic medical records. Unfortunately, none of them talk to each other, so we can't get the information back and forth across patients. We actually think that our model of putting the doctors, the hospitals, and every part of the system together is a model that can be used in a number of places. And we're putting together what's called Mayo Clinic Care Network. This is a group of organizations. There are 20 of them now. There will be about 10 more within the next year. Fairly good-sized organizations with a lot of physician involvement who have great track records. And we are basically selling our knowledge to them. They pay a subscription fee, and for that fee, they get access to Ask Mayo Expert, one of our contents. They get a lot of electronic consults, and we're finding the most common electronic consult is, what would you guys do next with a particular question? They get consulting, and then there are all kinds of options of, we're already talking about, what if we went to somebody like Blue Cross and said, all of us in Florida will do all of our hips exactly the same way and get that cost down. So we maintain the margin and we get the cost down. So dealing with this fragmentation and having people running everywhere, I think is a huge cost, and our model is one that's trying to make an effort at getting around that. Transparency is going to be a big one. You're starting to see people posting prices. I will just warn you that when you see hospital prices posted, they're totally meaningless. Totally meaningless. We all have price numbers, and we get paid different things by different insurance companies or Medicare or whatever. But this stuff is going to go away, and I agree with Ford. It's going to go away because more and more cost is going to be shifted to the individual. And when the individual starts saying, I have to pay $1,000 for this, what am I getting? Then we will start getting real transparency, and we're going to start seeing people move. All the more reason for us to finally figure out this value equation so we can say this truly is worth it or not. Interesting thing about the value, it's not just price. We do all of the solid organ transplants for Ford's Big Co, I think he called it, which is a major company across the country, and they will tell us, we've got a contract for all of their solid organs, that we are not the cheapest. We are not the cheapest, but we have the best outcomes, and we don't transplant everybody who comes through the door. We're looking for, maybe this one doesn't need it, this one can be treated medically, etc. So again, coming back to this value equation, focusing on quality, focusing on integration, focusing on transparency, it's going to get real interesting. This is one of the hundreds of groups that scores us all right now. This is Leapfrog. But another example of transparency, they're comparing resource use and a quality score on almost all the hospitals in the country. Each of us can get our own score from this group, but you can't get anybody else's. That's going to change soon, as everybody's name's going to be up here, and we're going to know who's using the resources and who has the outcomes. This will get very public. I can also promise you that as we go forward with this, it's still going to be ugly for a while, because we're all learning how to do this, and so once one rating agency gives you a great score, the next one gives you a bad score, and over the next 10 or 15 years, we're going to get to something that's probably pretty reasonable. And then finally, accountability. Accountability back to the patients in particular, as we say, what is it that we are really doing, and how much is it costing, and what are we doing for you? It's really not your picture. Now let me tell you two stories about what I see coming. One has to do with what's called regenerative medicine. We heard earlier about the cost of readmitting somebody for heart failure. Heart failure happens because somebody has a heart attack and part of the heart wall dies, and then the heart doesn't pump very well, or other things happen as they go along. They get an infection, the heart stops working often as we get older. We can already take punch biopsy of my skin, put it into a petri dish, and make those cells regenerate to stem cells. and then have them grow in the right conditions into heart cells. We can do that now. I've seen the beating cells in a petri dish. It is really weird. But we can do that, and the trial is about to start now of taking somebody's cells, make them go backwards to stem cells, grow them into heart cells, and then inject them into that wall of the heart. And then, therefore, take care of the heart failure. That's coming. That trial is beginning and underway. The other one that's very interesting is individualized medicine. This is a study that we are doing right now here in Florida, where we can take a patient's tumor cell, breast cancer, for example. This patient is at very high risk of recurrence because the tumor is large. So we can now take and do molecular profiling. We do the genomic testing on it. That used to cost $1 million. It now costs about $1,000. And it'll be much cheaper in the near future. We can do the genetic profile. And based on that genetic profile, we can determine which drugs to give that patient. We can take a piece of that tumor and start growing it in a mouse. We're basically making an avatar of that patient. And then at the end of the chemotherapy, we test the molecular profiling again, so that we're able to look and say, are we using the right drugs? Are we doing them well? And if that patient recurs, what's happening with the molecular change, and how are we going to approach that? We're doing that study now. Where that's going to save us money is, I'm an oncologist by training, and I spent a lot of time dealing with patients with breast cancer, for example, where I used to say, you know, I know that somebody that had the surgery has a 25% chance in a certain group of recurring. And my standard talk was, there's a 25% chance of recurring. There's a 50% chance that you've already been cured, and a 25% chance that I can cure you if we treat you. And I don't know who's who. So we treated all 100. That's been the pretty standard therapy up to this time. What we're about to see, and this is going to reduce the cost dramatically, is that we can say, here is your tumor, here is the genetic defect in your tumor, and these are the drugs that'll work on it. And that's happening already. So healthcare reform is upon us. I actually liked this quote from one of our founders. It says, I look through a half-open door into the future, full of interest, intriguing beyond my power to describe. I'm actually one of those people that says, I wish I was starting over like you guys, because I think the next 20 years is going to be incredible as we break through this. The key, as we go through all of this reform, the key is, let's remember to keep focusing on the needs of the patient. We heard a lot this morning about reimbursement and costs and dollars. We've got to keep it focused on the patient. Thank you.